Hi everyone, and thank you for joining us for our live MDA Engage Myotonic Dystrophy Symposium today. My name is Nicole Petrowski, and I'm MDA's Community Education Specialist. We appreciate you joining us today, and we're glad to be able to share such important information with you. I would like to thank our supporter for this event, Avidity Biosciences, as we welcome any of their representatives who may be joining us today. We appreciate your support. We are committed to community education, and we believe in bringing our community together for opportunities to learn from specialists and having opportunities to connect with others. This event is part of our larger MDA Engage series with disease-specific symposia, which we are hosting today, community education seminars, and community webinars as well. Here is the schedule of our upcoming community education seminars we will be hosting throughout the rest of the year. These are day-long educational seminars that provide individuals and families with knowledge and resources around neuromuscular disease. Information is shared by experts in the field on a variety of topics, and I encourage each of you to take a look at the agendas for these to see if they are of interest to you. And these are our community webinars we have lined up through the summer. Families can learn about different topic areas that are listed here, and typically these are about an hour long. Each webinar will feature experts in the field along with opportunities to ask questions from the presenters. Here's a look at our agenda for today. We have quite a busy day. I do have just a few housekeeping items before we do begin. First, and we get this asked a lot, we are recording today's event and we will be posting it to the mda.org website for on-demand viewing in a little bit later. And for those of you joining the event live, please know that all phone lines have been muted. We will be having a Q&A session at the end of each presentation. So please utilize the Q&A icon to type in your questions. If you hover over the bottom of your screen, a tray of icons will appear. Just click on the Q&A icon to open that feature and enter your question to host. You don't need to wait until the presentation is over before submitting questions. Feel free also to use the chat feature during this seminar if you have comments. Make sure you, though, click on all panelists and attendees when you type in your comment. That will make sure all the attendees can see your comments as well. And then you will notice on the agenda there are a couple small breaks between speakers. Please feel free to stay connected to the live broadcast during these times, but this will allow you time to grab some water or a bite to eat. And just so you know, this is also the time when I will be checking audio for the next presenter, so you will be able to hear us talking. We will be sending out a brief survey afterwards, and we would like to receive your feedback on what you heard today. We want to make sure what we're discussing are topics of interest to you, and we use your feedback as a way to improve educational events. We will be doing a drawing for 2 winners for a $20 Amazon e-gift card who submit a survey. So thank you in advance for completing that. And then just so you guys know, here is a look at tomorrow's agenda. So please note that if you only registered for today's session and you want to join tomorrow's, you will need to register for that. You could visit MDA Engage events page on our website and click on MDA Engage disease-specific symposia to register, just as you did for this session. Now, with that, a little bit of a long housekeeping list there. I would like to introduce our first presenter today, Dr. Laurie Guttman. Dr. Guttman is Professor and Chair of Neurology and Co-Director of the Neuroscience Institute at Indiana University School of Medicine. Her clinical career has been focused on care of people with neuromuscular disorders, including clinical research. She has developed several interdisciplinary clinics, including one for myotonic dystrophy, and has always worked in an MDA clinic throughout her career. She previously worked at West Virginia University, NIH, and University of Iowa. She did her residency and fellowship training at the University of Virginia in Charlottesville. So welcome, Dr. Guttman. I will turn it over to you and you can share your screen.
Well, first of all, thank you, Nicole, for inviting me to talk about recommended clinical practices for myotonic dystrophy. And I'm more than happy to answer questions at the end of this, but also Nicole can reach out to me if there are other questions along the way. I have the privilege of doing an overview of everything that everybody else is going to be talking about for the next 2 days. So there will be more in-depth information that will be available for some of the things I'm going to talk about. but we'll move forward and see what we can get through. So when I subtitled this a multi-system disease requiring multi-system care, because that really is the best approach to clinical practice for myotonic dystrophy. So first, my disclosures, if I can get this to change. I've been a consultant in the past for both Dyne Therapeutics and Biogen. Those are the only disclosures that are relevant to this particular talk. So myotonic dystrophy is a multi-system disease, which means that it's more than just a muscle disease. Not everyone who has symptoms from their myotonic dystrophy has symptoms from all the different systems. So don't think that this talk is to tell you everything that's going to happen to you during your lifetime. Some people never have symptoms from some of the systems, but it's important to be aware of them for preventive care, as well as when something happens and someone says to you, oh, that's just your myotonic dystrophy, you can say, no, I don't think that's it. Or if something happens to you and someone tells you it's from something else, you can know that it's, that the concern would be that maybe this is part of your myotonic dystrophy, and you might know a little bit more about it than the person, the healthcare provider who's taking care of you. The symptoms can be more of a problem at different times of your life as well. And it's also important to remember that there are different types of myotonic dystrophy. I'm putting this all into one bucket, but there's certainly type 1, type 2 myotonic dystrophy, both of which can share some of the same symptoms. And then also congenital myotonic dystrophy, which is, we're not going to talk about today, but there are some similar concerns, and I'll point you to some resources for that. So when I say it's a multi-system disorder, what do I mean by that? I mean that, as I said, it affects multiple systems. When you're in the MDA clinic, oftentimes the only thing you may think that we're thinking about are muscle symptoms, right? So weakness, wasting, the myotonia, the pain, but you definitely have a whole body involvement. So we have your vision can be involved, some cognitive changes can happen, cardiovascular problems, your bone, respiratory system, your GI tract, endocrine, reproductive system. So it's important, I think it's important for your doctor in general to think of you as a whole person, but it's also important for your doctor to be thinking about your disease as potentially affecting all these different systems. What kind of symptoms come from those system involvements? And I'm going to talk about some of them, and I'm not going to read these off to you. You can certainly read them yourself, but there are a variety of symptoms that can be related to your myotonic dystrophy, and it's important to realize that. And as I said, for prevention, as well as just to keep yourself healthy in general. There were consensus-based guidelines, care guidelines that were developed by international experts who care for people who have myotonic dystrophy. And these consensus-based care guidelines, I was fortunate enough to be part of the group that was involved in developing these, and it was educational for me as well as we were developing them, because you had people from very different areas and specialties who were thinking about people with myotonic dystrophy and how best we need to design some type of document that could be shared with both the people who have the disease, their caregivers, and their healthcare providers as well, to help guide people in the best way possible. So you could give it to your primary care doctor, and they would know that if you had a certain symptom, here was an algorithm or a path for them to follow as they tried to work up what was going on with you. And you can see there were quite a wide variety. I don't think I listed everybody. There were also palliative care workers, the care physicians. There were it was really an interesting process. And out of that process came these consensus-based care recommendations. And this link can take you to those, to the toolkit that you can then use as part of your care. The Myotonic Dystrophy Foundation helped to fund some of this and has shared this with, it's open share with everyone. So out of this came categorizing concerns for life-threatening symptoms that we should all be aware of, and then also other symptoms and when should we be concerned about them, what we should be doing about them, how can we educate ourselves. So for the life-threatening symptoms, I'm going to start with by talking about surgery, anesthesia, and pain control. And one of the things that can happen is that you might not even recognize that you have myotonic dystrophy after you have surgery. You're given the diagnosis because you have something that occurred during the surgery, such as difficulty waking up afterwards, or if you had to have a tube put in to help you breathe, your respiratory function isn't good enough to be able to get you off the ventilator fast enough, and you end up in what should be a day procedure ends up being something where you're hospitalized for a period of time. Other things that can happen with anesthesia is because of the cardiac involvement by myotonic dystrophy, you can have arrhythmias or irregular rhythms. You can have the respiratory compromise that I talked about. You can get jaw spasms. You can get pseudo obstruction of your bowel. So you get almost like you get a very painful abdomen, and this can also be can be life-threatening. Essentially, your bowel just stops working, and this can be accentuated by the anesthesia that gets used. You can also have more prolonged sedation than would be expected in someone who was given the same dose of medicine who might not have myotonic dystrophy. And most of the problems happen after anesthesia. So you may be screened for anesthesia and nobody is concerned, and then they do the anesthesia. Some anesthetics can be more of a problem than others. And then after the procedure, that's when more of the problems occur. So knowing that you have myotonic dystrophy, your team knowing that you have myotonic dystrophy before you go in for surgery, before you have anesthesia, before someone gives you medication for pain control is really important, so that they can avoid those problems after anesthesia. So when we talk about life-threatening symptoms not related to a surgical procedure, but in respiratory care and in general, you need to monitor for your cough. So people with myotonic dystrophy and other neuromuscular diseases can often have their respiratory muscles affected, and they may not be able to have a good cough. They may not be able to clear their airways as well. If you get ill, that may be affected more, putting you at higher risk. So if you notice that your cough has become less strong during an illness, that's definitely a time to be not waiting to see what's going to happen. Or if you already have a weakened cough, when you get ill, it's important to get help sooner rather than later. The other thing is get your vaccine, not just for COVID, obviously, but your flu vaccine. It's important for people to prevent, as a preventive measure, to get vaccines so you don't get flu, so you don't get COVID. And then watch for snoring or increased snoring, because this could be another sign that you're having increasing respiratory weakness and impending respiratory failure. And the last thing I want to say is be careful with supplemental oxygen. Sometimes people will just keep increasing oxygen, and in myotonic dystrophy, you may not respond as well to higher doses of oxygen as someone who doesn't have it, because you may be running your whole life with a slightly lower oxygenation. Your body's accommodated to that. As people turn up the oxygen, then your breathing actually may get suppressed. So it's important for people, again, to be aware that you have myotonic dystrophy and what that means to you for your health. Other life-threatening symptoms would be your heart. If you notice that you're having some palpitations or you have a slow heart rate, you feel like your heart rate's really slowed down, you're passing out, you have chest pain. Those are reasons to not wait and definitely go get evaluated. Even if you had an EKG recently, it's not something to be ignored, as it can be fatal. It may be that something's changed. You may need a pacemaker and or an implanted defibrillator. So you really need to see a cardiologist. And then the other issue for life-threatening symptoms is pregnancy care. If you get pregnant, you need to know that it's a high risk, you're in the high risk category. Now, many people with myotonic dystrophy have absolutely uneventful pregnancies. That's what we all hope for, but being monitored more closely for both the mother and the baby is really important in myotonic dystrophy. Prenatal care, making your whole team aware, things that can happen for people with myotonic dystrophy. Sometimes the delivery itself, you can get muscle fatigue, more so than someone who doesn't have myotonic dystrophy, and other things that can occur, including compromising your respiratory status, because as your belly fills up, right, our lungs get pushed up and you can't take as deep a breath. So really having regular appointments, being part of a high-risk team. And then you want to have a neonatal ICU available. Mothers with myotonic dystrophy can have a higher risk of having a baby that's going to have problems potentially with swallowing, respiratory status immediately upon delivery. Now, certainly not, as I said, many people with myotonic dystrophy and many deliveries are just fine, and many of you may have had those. So I just think that we know that these are potential problems, and being part of a high risk team that knows your disease and knows what to watch out for makes everything go that much smoother. So let's step away from life-threatening things and just talk about symptoms in general. And I'm going to go through these as I mentioned earlier. So myotonic dystrophy is known for myotonia. So those of you who have the disease may certainly know what this is. Some people don't have very much myotonia, but it's the difficulty releasing a muscle after contracting it. So you make a fist and then you hold it and then you just can't relax it. It can happen in any muscle that you have. It can happen in your jaw, your tongue. People talk about, standing up suddenly and then feeling like their legs lock and they almost feel like they're going to fall over. And if they wait a minute, then it releases and then they can walk normally. So it can happen to any muscle. It's worse when it's cold. So when it's your hands that are the biggest problem, which is the most common muscles that people complain about the myotonia in, wearing gloves in the winter, even when you're when it's just cool out or cool and damp, it really helps to prevent some of the myotonia. And then the other thing to do is to do repetitive movements, and then the myotonia actually fatigues. So if you have to do something to open and close your hands a few times, one of my patients who had to give a lot of talks would sometimes feel like when she stood up to give a talk, first thing that would happen is her tongue would lock. So she would practice some movements with her tongue inside her mouth before she spoke. So she wasn't standing there like sticking her tongue out and moving it around, but and inside her mouth, just to do the repetitive movements to loosen it up. There are medications that can help. Mixilotine has been shown to be helpful for reducing myotonia. There are also other medications that you can try as well. And this is something that you could discuss with your neurologist. I will say for some people, the myotonia it's just part of how they live, doesn't interfere with what they're doing, and taking medications is just one more thing they don't want to do. And that's perfectly acceptable too. Many people have had myotonia and don't know that it's related to a disease. You just accommodate for it. But if you feel like it's a problem, there are medications to take. So what about muscle weakness? So the problem with muscle weakness is that you have risks for falls or injury. It can also result in, if you don't stay active, obviously weight gain can be another problem with this, which is not healthy in general. So just normal health is important. You can use orthotics or braces, which can be helpful to prevent falls or injury and help you move more safely. When it's your hands, occupational therapy can be helpful. You can get tools to help bypass the weakness. And then regular exercise. If you're concerned about falls or you're not sure what is the safest type of exercise for you, you can check with a rehab specialist or a physical therapist, someone who understands neuromuscular disorders and can work with you to help you stay mobile, independent, and safe, and also doing all the activities that you want. And then the other thing to think about with muscle weakness is energy conservation. Now, I just told you to do regular exercise, so how does that make sense? Well, if you work with the rehab specialists, it's amazing how a brace can, for example, when you have foot drop, how a brace can really help you walk more efficiently and really conserve energy. How tools that the occupational therapist gives you makes it easier for you to do your activities of daily living, so you're not wearing out just doing things in the kitchen or dressing yourself because it's just too much work. So this is another important thing to think about, is conserving your energy. You'll hear me say this again. So what about muscle pain? Muscle pain can be a part of myotonic dystrophy. Sometimes for type 2 myotonic dystrophy, it can be the presenting symptom. And it's important to think about how to deal with that pain. Regular exercise, again, can be very helpful to reduce pain. Sometimes the pain is made worse just by shortening of muscles. So stretching, getting some stretching exercises to help reduce some of that pain. Some people think massage is very helpful to reduce some of that pain. There are other things people have done, acupuncture. There are some of the myotonia medications can help with the pain, and other medications that are often used for fibromyalgia, which is what the pain seems most similar to. We don't really understand why people have muscle pain in myotonic dystrophy, but it is definitely a part of the disease. You want to avoid painkillers, and just direct pain medication if you can. There are other medications that are useful that are not sedating, that don't affect the bowel function, but those are it's worth talking about it and then trying to put some regular exercise. When I say regular exercise, I'm not talking about like going out and walking a mile or 3 miles or running a half marathon, or, I mean, if you can do that, that's great. But really even just 10 minutes, 5 to 10 minutes, a couple of times a day where you just get up and walk around, or you do things with your hands or arms, important to help reduce some of the pain. Another symptom is sleepiness and drowsiness, or and then fatigue. And I separate these because a lot of people talk about excessive daytime sleepiness as part of the sleepiness and drowsiness. The fatigue is sometimes related to this, but sometimes people have fatigue that is not necessarily related to a sleep problem. But the first thing that you should be aware of is that your respiratory system, if you're not breathing well, you may be causing some of the sleepiness and drowsiness. And so assessing your breathing, having a forced vital capacity done, seeing either in your MDA clinic or through pulmonary clinic is useful. A sleep study and screening for both apnea, where you stop breathing, or narcolepsy, where you fall, is another sleep disorder. Both of these can occur sometimes together in myotonic dystrophy. And then if you are given a device to wear, I underline this, wear it, because it will make a difference and it will make you feel better. Now, the problem with wearing a device, and I think you'll hear some more discussion about sleep disorders in more detail, but I just want to say, find a mask that's comfortable and fits you. There's many more options than there ever used to be. They're quieter. Some people say, oh, I don't want to bother my partner. They're much quieter than they used to be. They're smaller than they used to be. The one issue is that if you have hand weakness, it can be difficult to put it on yourself. You can take your machine and your mask to your occupational therapist. Many times they can come up with different ways that work for you so that you can put the mask on comfortably yourself. So wear your device if you have apnea or you have narcolepsy. And then other things that can contribute to sleepiness and drowsiness that you need to think about is getting your thyroid checked yearly, as well as your glucose. And for males, if you're having a lot of fatigue, testosterone, some people also say for females, but it's worth definitely getting your thyroid and your glucose checked every year. There's an increased risk of diabetes in people who have myotonic dystrophy as well as thyroid disease. There are medical treatments. You can try modafinil and similar drugs like that, if you've heard of those, to help with the excessive daytime sleepiness. And then again, energy conservation. Some people are just fatigued because it's so hard to do anything that you're using all your energy to take care of yourself. And then again, regular exercise. So just making sure that you don't get deconditioned, making sure that you're moving around really can help reduce fatigue. And just even a short amount of exercise can give you more energy. Shortness of breath, I talked about this a little bit before, but you should, if you're having shortness of breath, that evaluation of your breathing, both sitting and lying down, again, is important. Seeing a pulmonologist, making sure that you get cardiac screening every year. Whoops, sorry about that. And again, be aware that too much oxygen can be a problem. Just make sure that whoever's prescribing your oxygen knows that you have myotonic dystrophy and is aware of that as they put together the setting for how much oxygen you should be using. Some cardiac screening beyond the yearly EKG, just to say sometimes it requires you to have Holter monitor. Some people recommend a Holter monitor intermittently, cardiac MRIs, echoes. There's lots of different things, and having a cardiologist, again, who understands your disease and knows what to be looking for on your EKG is important. Vision changes, you should have a yearly eye exam with a slit lamp, which is, I usually recommend that you see an ophthalmologist for your yearly eye exam. You want to be looking for cataracts. Rarely people can also have changes in the back of their eye and the retina, so it's something else to be looking at. The other thing is eyelid drooping can be a problem for people with myotonic dystrophy. So we call that ptosis with the P silent. And there are non-surgical or surgical treatments, including things like eyelid crutches and lid lifts. So I had no idea when I was a resident, when someone talked to me about eyelid crutches, what that meant. And I'll include this here. These, you can put them on the glasses and they actually slide and pull your eyelids up. not quite looking like I had in my mind when I first heard about it. I was thinking like these little crutches that you would stick in between your eyelids. That's not what it is. It just holds it up that way. Dry eyes can be an issue as well because of some of the changes that happen to the facial muscles. And sometimes people will complain that their eyes water all the time. Sometimes our eyes water because they're so dry. And that's our body's response to it. So if you're having very watery eyes, you can try saline eye drops, or if you're feeling like your eyes are especially dry and you're having to blink frequently, that can help. And if they don't help, then you may want to see an ophthalmologist. There are some other non-surgical and surgical treatments for dry eyes as well. Speech problems. Because of the changes in the facial muscles and the weakness of the facial muscles, as well as the tongue and inside the mouth muscles that can get weaker, people can sometimes be slurring or mumbling or have soft speech. The way to approach that would be with a speech therapist to give you potentially some training or devices. And one of the most common things they talk about is slowing down, positioning your head and your face so that you're speaking towards someone. You may not have the same volume. There are other techniques that can be used. And then just being patient and reminding yourself to slow down. And patience also includes the people who are listening to you. You need to encourage them to be patient with you, that you're going to speak more slowly. Some people use microphones. Some people use touch screens or talk devices if they're in a situation where they're feeling nervous about being able to be understood. There are lots of ways to get around that. Sometimes people have difficulty finding words, and I'll talk a little bit about some cognitive changes that can occur, but the key thing for this is just having patience with yourself. Sometimes slowing down will help you with finding the words. Gastrointestinal problems that can occur. So what do I mean by that? Your stomach, your bowels, but your gastrointestinal system starts with just swallowing, right? So swallowing can be affected by the muscle weakness and by the myotonia. The key thing is to slow down, take smaller bites, change your food consistency. Sometimes a speech therapist can be really helpful when you notice a change and you're not being able to control this. You feel like you're choking more. Working with a speech therapist to find ways to accommodate. But if you can't do that and you're having significant weight loss, a dietitian consulting may be helpful in determining how to increase your calories. Some people do end up needing a gastrostomy tube, and I just want to show you a picture of this. So here you can see that when we talk about a gastrostomy tube, it's just a small tube that goes into the stomach. Actually, usually extends a little bit more in, but it locks in place here and on the skin. And then it's under your clothes. You don't have to see it. You can still eat by mouth. It doesn't interfere with anything above it or below it. So you can still eat, but you can get extra calories in if it's taking you longer to eat and you can't get the calories in. That may be the solution to prevent more weight loss. And weight loss can be unfortunate in people with neuromuscular diseases because oftentimes we lose muscle when we lose weight first, because it's easy for our body to break down muscle, much easier than it is, as all of us, anybody knows who's tried to lose weight by dieting, then it's hard to lose fat. Other gastrointestinal problems include stomach and gut issues. People can have more reflux or stomach pain. And one thing to think about is to avoid foods that trigger this. And again, a dietitian can be helpful. Don't eat before you go to bed. But don't forget that gallbladder problems can occur more frequently in people with myotonic dystrophy. So you may not want to ignore it completely. If you're having reflux and stomach pain, that is persistent, you may want to see your primary care doctor and discuss about being screened for gallbladder problems. Standard medications can be helpful, though even over the counter if it's primarily reflux, but persistent stomach pain should not be ignored. Constipation and diarrhea are also problems that we see in myotonic dystrophy. Many people have irritable bowel syndrome. Sometimes that's the symptom that predated their diagnosis of myotonic dystrophy. And you may need a gastroenterologist to be involved. Knowing that you have myotonic dystrophy can help prevent you from getting a whole slew of tests, but they still may want to do things like check for bacterial overgrowth because of slow transit of your bowel. They may want to do ultrasound of your gallbladder, etc. And some of the medications that you use for irritable bowel syndrome may be the same as they would be whether you had myotonic dystrophy or not. But it's important to remember that it's not, oh, well, it's just part of my disease that I'm going to have constipation and or diarrhea. There are things that we can do to help. One thing is to also regiment how you how you're going to make sure that you get you try to have a regimen for your bowels, eating food that has fiber in it to help you. Over-the-counter treatments can sometimes be helpful. Regular exercise, if I said that once, I've already said it probably 4 times, does help. We know that exercise helps with bowel transit, so that's another reason to get up and walk. And then there are different devices that can help with constipation, especially if you haven't seen a squatty potty. This is, I think you'll probably hear a little bit more about this in the longer talk on GI, but this is really a helpful tool by elevating your legs and changing the position of how you're sitting and allowing you to empty your bowels more easily. Really beware of life-threatening problems. We talked before about pseudo-obstruction, or even with constant diarrhea, people can get dehydrated. You know, don't ignore problems that are persistent. Make sure that your medical team is aware. The endocrine and metabolic system can be affected. I mentioned earlier already that there's a higher risk for thyroid disease and insulin resistance and diabetes. And so you want to get the yearly blood work that we talked about before. Low testosterone, fertility, and menstrual problems can also be more of a problem in people who have myotonic dystrophy. And if you have symptoms, you may need treatment for them. The low testosterone can occur in both men and women and can be associated with significant hair loss. And there's medications that you can take that might be helpful for that. You can also sometimes see high lipids, more of a problem in myotonic dystrophy, slightly higher than the general population. So monitoring your lipids on a yearly basis, like your cholesterol, your LDL, your HDL, and also your liver function. Now, sometimes people end up with a liver biopsy when they have myotonic dystrophy. If you have changes in your liver enzymes, you may want to make sure that your doctor knows you have myotonic dystrophy. If they fit into the pattern that you would expect with myotonic dystrophy, you may be able to avoid having a liver biopsy. If they don't, then you need to be treated. It may be a completely separate problem for your myotonic dystrophy, and need to be treated in that particular way, depending on how the changes, what the changes look like. Neuropsychiatric problems can occur in myotonic dystrophy. And again, I'm just going to reiterate that I'm not saying if you have myotonic dystrophy, you're going to have all of these things, but I was given the assignment to cover all of them. So just to know that this can also be a part of the disease as changes. We do know that some changes occur in the brain. Probably the most common thing that we see is a lack of motivation or apathy. And the thing to do with this is so treatments for this could include things like making sure you schedule events, schedule a Zoom meeting. Now, before COVID, you would schedule something like going to an event at your church, or regularly going to meet somebody at a coffee shop or something like that. Hopefully we will be able to do that again instead of this Zoom format, but Zoom works as well. And one of my patients got a dog because then she knew she would get up and do things twice, at least 2-3 days, to get up, walk her dog. And that served two purposes, right? It was a scheduled event that she knew was going to happen during the day, and it gave her regular exercise, which, did I say that was important? That's important. And sometimes the apathy is not a bother to the person who has myotonic dystrophy, but more so to the people around them. And so having them understand that this is part of the disease can sometimes be helpful for peace in your home. So anxiety and depression can also occur in people with myotonic dystrophy, just like people who don't have myotonic dystrophy. Counseling is just as helpful for people with myotonic dystrophy, and as are the medications. And you just want to be sure that you that whoever is giving you the medication knows you have myotonic dystrophy, so they screen for side effects. I want to go back to just the apathy. And the other thing about that is that it can be misinterpreted as a lack of, sometimes people think you're apathetic because of your facial muscles not necessarily showing as much expression when you're at rest. And so it can be misinterpreted as a lack of engagement or apathy. But apathy truly is a part of this disease. Thinking and cognitive changes can occur in some people with this disease at different stages, depending on your disease. Ways to accommodate for that include the same as people who didn't have myotonic dystrophy: writing down things, making lists, having computer tools that remind you. So setting an alarm a certain time of day to take your medication, or to take your walk, or to call someone, if those are the kind of things. So using different tools on your computer, and then just being patient with yourself and ask those around you to be patient with you as well. Lastly, cancer screenings. There may be a slightly higher risk for certain types of cancers in patients with myotonic dystrophy. And I list them here. The key thing is, though, there's no reason to be concerned beyond general screening for these. And you should be doing that anyway to try to maintain your health, regardless of whether you have myotonic dystrophy or not. And so that's the primary thing, is for people to be aware that you just need to be more diligent about making sure you get your regular screening for your exams, for your blood work for your thyroid, for getting your colonoscopy. And then there is an increased incidence of these funny tumors, skin tumors that can occur. Funny because it's a name I'm really bad at saying, pilomatrixomas. They're not malignant skin tumors, so they're not a cancer, but they can sometimes be annoying and troublesome. They're easily removed surgically, but it's not a skin cancer. So these are the symptoms that we walked through, most of them. I will say that there's definitely hope for the future, and other people will be talking about this as well. I think Jacinda is talking about some clinical trials after this. As we have a better understanding of the disease itself, it leads to better treatments in the future. Having a care team that knows your disease is important, and understanding what your team needs to know is also important. So to remember that when it comes to your symptoms, It's important to educate yourself, which you're doing by attending these webinars that are provided by the MDA, but also educate your team. Sometimes you know more about the disease than your primary care doctor, than sometimes your neurologist, depending on their experience with myotonic dystrophy, and you can really help them by educating them. The majority of people will be grateful for the education that you share with them. It doesn't mean that they don't care and that they are not adequate physicians or caregivers. It just may mean that they've never come across someone with your disease before. Most people are more than happy to be educated. So remember, always pass on what you've learned. And now I'm happy to take questions.
Thank you, Dr. Guttman. That's cute. Being a dog lover, I thought that was really cute. All right. We have a couple questions that have come in. This person says that their daughter has problems with cold IVs after surgery. Once they warm the IV, her recovery sped up. Could this affect her because of myotonia?
I don't think so. The IV itself, I don't think so.
Okay. And then we also had someone comment, people need to know about gastroparesis, where one needs to limit the amount of fiber they eat. This person had an example where she was eating too much fiber and it caused severe constipation problems. So I just wanted
yeah. So the gut transit, that's actually a good point, because I did mention eating fiber, but eating fiber doesn't help you if you don't drink enough fluids. That's one of the things that can happen.
Okay.
And also making sure that you have that you're having regular bowel movements. I mean, it sounds like it's the opposite, right? I tell you to eat more fiber,
Exactly.
regular bowel movements, but if you're not having regular bowel movements, you can end up with what's called a pseudo obstruction, or that's why I mentioned before, people talk about bacterial overgrowth as well. I think if you're having a lot of problems, consulting with your primary care doctor or a gastroenterologist to find what's right for you.
Okay. And next we have a two-part question. Apart from daily aches and pains, how common is it to have major pain flare-ups that cause debilitating full body pain? Is that very common?
No, some people have generalized pain, as generalized muscle pain usually is not debilitating, but it can be for some people, but a flare up and down, not so much so. And those are the kind of things where I mentioned earlier that you want to say, okay, this might not be my myotonic dystrophy. I need to see someone. And if they tell you this is your myotonic dystrophy, you say, well, I've never really had this before. This is new. And they need to explore. Unfortunately, just because we have one disease doesn't mean we can't get something else, right?
Mm-hmm. This person was commenting it was, they have DM1.
Yeah.
And the part two to that is, besides Cymbalta, are there any types of fibromyalgia medication that has been helped to be proven to help with pain?
So there's a whole list of different medications people talk about. I would definitely discuss it with your doctor. There are other things besides Cymbalta that can be helpful.
Okay, perfect. This person wanted to have you kind of reiterate about the endocrine system. She was a little bit late. She didn't understand exactly what you were saying. Could you repeat some of that perhaps?
Yeah, so the endocrine system can be affected, and okay. And that can mean like your thyroid, your ability to handle glucose, so you have a higher risk of having diabetes. Also, some people have trouble with fertility, both male fertility as well as women. Women can also have more painful menses, so your periods can be a lot more painful. And then a slightly increased risk of miscarriages, which may or may not be related to the endocrine system, but those are the kind of things. Additionally, people talk about, I didn't mention this, there's can be effects on calcium. And so monitoring your calcium and your vitamin D, or taking regular vitamin D, can sometimes be helpful.
Okay. You said be careful with oxygen. This person commented they don't need oxygen during the day, but use an Avap at night. I have different thoughts from my sleep doctors on whether or not I need oxygen at night. Do I need to be concerned with the amount of oxygen with when the Avap is helping me breathe at night? Is your
I
okay?
think it's probably fine. And I just mean sometimes, especially, it's more of an issue in an emergency situation where they may just turn up the oxygen to a higher rate, and that can be a problem in slowing down your breathing and your respiration. So I think,
Oh, okay.
yeah. So maybe I wasn't as clear as I'd like to have been on that.
Did you say anything about treatment for hair loss?
I did.
What's your recommendation for that?
So there's not great treatment for it. Sometimes people can use minoxidil, which is, or one of those other drugs like that to help with hair loss. I will say that most of the time it's not that successful. So it's unfortunate in this disease that part of the problem is it can be hair loss. Now, again, the caveat is that if it's something that's new and happening to you, you should get your thyroid checked because low thyroid can also cause hair loss. So.
Okay. Is it normal for myotonic dystrophy or folks with myotonic dystrophy to have heel pain, especially when they're walking?
No, and that would be, if you're having a lot of heel pain, it would be worth looking at, talking to your doctor about it, making sure there's not something like a stress fracture, but also seeing if different shoes or orthotics might be more helpful for you.
Okay. And we have a person who is a caregiver that has a question. They're a caregiver for their 16-year-old granddaughter who has congenital DM1. At what age should the yearly screens for thyroid lipid levels and insulin be started?
I actually don't know the answer to that question.
Okay, that's fair. If you have sleep apnea but can't wear a mask due to claustrophobia, is there anything that you suggest?
Yeah, I'm going to go back to the previous question. I would say if you're suspicious or concerned at age 16, it's probably worth screening at least once. In the adult clinic, we just do it standardly every year. I think by the time you're 16, I think at least screening once, if there are symptoms that you're concerned about, is worth doing. So,
okay.
And what was now you have to ask me the question again. Sorry.
About the testing? Is that what we were talking about? I have a plethora.
Oh, okay. Well, then maybe you'll just have to keep asking questions.
Hold on. Oh my goodness. No, I'm going through all these questions here. You guys have a lot of questions today, which is awesome. Sleep apnea, if you can't wear a mask due to claustrophobia.
Oh.
Do you have recommendations? Sorry.
Yeah, there are other masks to use, and there are actually some more interesting devices. I know that Jacinda is on. I don't know if she wants to speak up if she's not on right now. That's one of her areas of strength. That's different from mine, but there are different masks, some that are just like nasal pillows that can just fit right on your nose, so you don't feel like there's something covering your face. Well, sometimes people don't like it because the strap around your head. Work with your respiratory company to find something that makes you feel comfortable enough to do it.
Okay, that's very good advice. Some nights they have a hard time getting my muscles in my legs to relax. Is there something they could take to help with that without affecting their heart?
Yeah, it depends on what you mean by getting your legs to relax, but there are definitely a variety of medications that you can use. I would talk to your doctor about that. Some people also just do stretches before they go to bed, and that can help reduce some of that. It's worth trying that as well.
Okay. Is there an increased risk for the overall general population for use of Botox or pain, specifically migraines?
No.
Okay. And is insomnia part of DM?
Um, it can be sleep disorders in general. One of the problems that happens, I mean, the first thing to do if you're having insomnia is to really look at your sleep hygiene, as we call it, right? Mm-hmm. So if you're napping a lot during the day, you're not going to be able to fall asleep at night. If you're using a lot of caffeine to keep yourself awake during the day or taking medications, if you take it too late in the day, you're going to have trouble falling asleep at night.
Okay, so that's a good point.
Yeah, so really talking to your sleep specialist about that. And I will say, just to reiterate why I made such a big point about making sure you wear your mask when you have sleep apnea, is that you can, sleep apnea can cause effect on your heart, can cause effect on your brain. We know that people who have untreated sleep apnea have a higher risk, even if you don't have myotonic dystrophy, of cardiac arrhythmias, right? Okay. Or cognitive changes. So really making sure you get your sleep apnea treated is important.
All right. And I just want to say too, we have Dr. Diebold's that is going to speak later about sleep disorders and myotonic. So we can actually address a lot of those sleep issues this afternoon as well. What is the difference between Avap and CPAP?
Oh, you froze, Nicole.
Oh, can you hear me? Okay.
Yep.
Are you there? It says my internet is unstable. Of course it's unstable, of all days. What was I asking? The difference between Avap and CPAP.
I'm going to leave that to the sleep specialist.
Sleep person, okay.
I mean, there is a difference but to have me try to explain it.
Sure. After prolonged amount of exercise, are convulsions or vomiting common? Two of this person's children have seen this problem. Yeah.
No.
That's not good.
No.
Okay. And I want to be mindful of our time. It's almost at the top of the hour, and I want to make sure we give people a little bit of a break here. But since this person's asking about, since her menopause, she's needed hormone replacement therapy. Is there an alternate to medications for that, or is DM, because I have DM, is that also affecting her hormones?
No, I think you would treat menopause and menopausal symptoms the same in someone with DM as someone who doesn't. And that's true for many of these symptoms. You just need to be aware and avoid medications that can affect your muscles. But for post-menopause, I think, or menopausal symptoms, you're fine just getting the treatment that you need.
Okay. And again, this person is commenting, she'd love to have regular exercise, but even just a little exercise, makes her extremely tired. And she's just wondering, how can a person conserve just some energy to do regular exercise? And also, can it help fix insomnia at night versus daytime? So, and you made a comment too about taking that medicine at a different time.
Yeah. And the other thing is, if you haven't had a consultation with a physical therapist who understands the neuromuscular disorder. So not a physical therapist who does predominantly knee replacement, physical therapy, or hip or sports injuries. You want someone who understands neuromuscular disorders to help you develop some type of exercise program that you can slowly build up some of your energy. And you may not be able to because of your disease, because of your respiratory status. Mm-hmm. And that is a very frustrating thing. But I think if you haven't had a consultation with someone, either a physical medicine and rehab person or a physical therapist who works with neuromuscular diseases, I would definitely recommend it. And you can talk to your MDA doc if there isn't somebody locally, mm-hmm. may be able to find you someone to just even a one-time consultation.
That's great advice. That's great advice. The last question I'll take here is, in DM1 adult onset, this person says that they've had significant toe cramping and curling, like with the hands and fingers. Is there anything that can be done for this? They're afraid of getting hammer toes.
It depends on if it's the myotonia or not, but I think if it's the myotonia, there are different medications that you can take to help with the myotonia to some extent. If it's the myotonia, it shouldn't result in hammer toes or joint abnormalities, though. So if they're seeing hammer toes, they may want to see if there's something else going on besides their myotonic dystrophy.
Okay, makes perfect sense. Well, thank you very much, Dr. Guttman. We got through a lot of our questions, so I appreciate your time today.
Well, thank you. Thanks for inviting me, and thank everyone for their attention.